Let me in when the meeting starts.
Yeah. Mm-hmm. Hello, good afternoon. Edna, please, you are ready. Hello, good afternoon, everyone. Please, can you hear me?
Yes.
Okay. Yes, please. All right. You're all welcome to our meeting today. We apologize for the late start. We had a little technical difficulty joining online. My name is Nanama Wedibose. I'm the program manager for the Antimicrobial Stewardship program at UGMC. We have other members from UGMC on the call, so we'll begin with introductions. We'll start by introducing ourselves, and then the team from Ghana Health Service will also introduce themselves, and then we would go straight to the agenda for today. Director, please, would you like to start?
Thank you very much. Good afternoon to you all. My name is Joseph Mesa, and I'm the Director of Pharmacy here at UGMC. I'm happy to be here.
Thank you, Director. Please, any other members from UGMC can just unmute and introduce themselves.
Okay, hi, good afternoon, everyone. My name is Daniel Freeman, also answer. I'm also a member of the AMS. Thank you.
Thank you. I believe that is it from our end. So our colleagues from Ghana Health Service can introduce themselves now.
My name is Anai at the Office of Director of Pharmaceutical Services. And on behalf of my director, who is indisposed at the moment, we want to thank you very much for making time to be with us and to do this training for us this afternoon. Yeah, thank you.
Thank you.
Yeah. Hello there. I am Claudette Jogo, also from the same office with Lady Edna. Thank you, and over.
Thank you. Very nice to meet you. We have one more member from UGMC here.
Hello, everyone. My name is Dr. Farida Sewa Gobe. I'm a senior specialist in infectious disease.
Thank you, Dr. Gobe. It's very nice to meet all of you. Would you let's say a few words before we make the presentation.
Just one more, please. There are more people from the Office of Director of Pharmacy that need to introduce themselves.
Okay. All right.
Dr. Osu, please, did I hear director's voice? Is he back in the office? Yes and no. Okay, that's fine. Okay. That's fine. That's fine. It's good to know the director is really committed to this. That's why he has popped in to make sure that, this is happening and then we are on course. So thank you, director, that even in spite of all that you are doing, you still have time to be with us. Thank you. Please, I just want us to know that Dr. Mary Eke will be joining us, IHP.
I have joined.
Okay.
I have joined, please. Thank you.
Okay, please. Okay. Then introduce yourself.
Oh, okay. Good morning to us all. My name is Mary Eke from Project, the Senior Technical Director of Drugs, Diagnostic Devices, Vaccines, and Antimicrobial Resistance. Thank you. Over.
I think we are all set. Please, you may go ahead.
Thank you very much. Dr. Mensah, please, would you like to say a few words before we start our presentation?
Certainly. Thank you, Nana. Thank you very much. On behalf of the management, the Pharmacy Directorate, and the Antimicrobial Stewardship Committee and team, I would like to welcome you all to this presentation. This partnership has been great so far. We started off with WhatsApp messaging, telephone conversations, then we met for the first time at UGMC for a fruitful introductory meeting, verbal update on New Year. And we promised to share necessary documents with the team, which we have provided. And the next step was to do a PowerPoint or give a PowerPoint presentation, which would streamline or which would outline what we do again, and then give a few pointers moving into the future. We hope to get this done within an hour, and then we'll be out of here. And so we are grateful that you have joined this meeting. At the end of the day, we'll be available to answer all questions. After this, then we move to the next step. Thank you very much. Nana, kindly forward.
Okay. Thank you all once again for joining us for the meeting today. And we are grateful that you approached us to share experience in GMC with your team. My name again is Nana Mausei, and today I'll be taking you through the UGMC Antimicrobial Stewardship Program in the subsequent slides. So please, can you see my slides?
Yes.
Yes, please.
Okay, so stewardship.
Yeah, no, sorry. Please, let one more person in for me.
All right. Please, there's no one in the lobby.
Okay, well,
we'll keep on checking.
All right, thank you.
All right. So stewardship, we all know, is a word that defines the conducting, supervising, or managing something. So when we say antimicrobial stewardship, we are looking at a set of actions, coherent actions that ultimately ensure the use of antimicrobials to improve patients' outcomes while limiting the risk of adverse events, particularly antimicrobial resistance. And so ultimately, what are the goals of any stewardship program? we set out to implement specific efforts to optimize antimicrobial prescribing by making sure that the right medication in the right dose and the right duration is prescribed for our patients. And antimicrobial stewardship programs are vital components of any national action plan for AMR and significantly reduce AMR, particularly when coupled with IPC interventions. It's very important that we note that IPC and AMS working hand in hand together is more powerful than working in silos. So what is the rationale for any AMS program in our healthcare facilities? There are risks of prevalence of nosocomial infections, increase of heavy use of antibiotics, presence of patients with previous exposure to antimicrobial agents, exposure to invasive devices, prolonged hospital stay, immune suppression, malnutrition, increasing antimicrobial resistance. These are all risks that we see daily in our wards. Hence, the need for antimicrobial stewardship and establishment of antimicrobial stewardship programs and capabilities. Again, the goal of any EMS program is to ensure optimized clinical outcomes while reducing antimicrobial resistance, reducing mortality and length of stay of patients, and healthcare associated costs related with the management of infections in facilities. And so, for any antimicrobial stewardship program, there's an international consensus that these 7 core elements must be the baseline in any ASP program that is established. And these factors were derived from WHO and the Centers for Disease Control in the USA. So the first is senior hospital management leadership support toward AMS, accountability and responsibilities, available expertise on infection management, actions and interventions, monitoring and surveillance, reporting and feedback, and then education and practical training. So it's important to note that you do not have to have all 7 in place at the same time. You just use this as a checklist to let you know where you are and what you have in place and what you need to do in order to achieve everything under these elements. So these are the guidelines that the 7 core elements came out of, the CDC checklist and then the WHO guideline for low and middle income countries for establishing antimicrobial stewardship programs. Okay, so this is the framework we use to establish our AMS program here in UGMC based on the core elements. So the first is to ensure that we have leadership commitments like the core elements recommend. And then we established an AMS committee and team. The team and the committee underwent training to ensure there was sufficient knowledge in AMS for implementing our interventions. And then we began with an AMS situation analysis, assessed baseline antimicrobial prescribing, developed an action plan, implemented the interventions, and then put in place measures to monitor and track effectiveness of the interventions. And another key factor was also promotion of collaboration and communication of findings from all the activities that the program is in place. So in the subsequent slides, I'll be taking each factor and then sharing the UGMC experience with the team. So the first step in our framework was the establishment of leadership commitment. This is very important. In our experience, the initiative came from core management, just as Ghana Health Services is seeking to do, to set up the AMS program. Without management support, it is very difficult to implement some of the interventions you have in mind. For us, fortunately for us, management initiated the setup, and it's the committee, and it's made up of the Antimicrobial Stewardship Committee and the team, headed by an infectious disease specialist. Especially for us, again, now a member of management in the committee as the director of pharmacy, and this has been very instrumental in making sure that our interventions are fruitful. So the AMS committee serves as an oversight mechanism for the AMS team. They are the approving authority for all AMS activities in the facility. And it includes relevant stakeholders and members from other relevant committees. I would elaborate more on in the subsequent slides. They develop the terms of reference and then outline clear objectives for members and as well as activities and interventions we wanted to put in place. And progress of all AMS activities reported to the committee by the team. And the AMS team is set on the committee, so we consider it as a subcommittee of the AMS committee. And the team consists of a dedicated focal point person to serve as the AMS champion. And it's also a multidisciplinary membership with a physician, a pharmacist, and microbiologist, and then a nurse with IPC experience. Okay, so this is just a breakdown of our committee. Like I said, it's a multidisciplinary committee. It has 23 members that meets monthly. And for us, we meet on the last Tuesday of every month. We have 9 doctors across 7 specialties, 5 clinical pharmacists, 2 medical laboratory scientists. And we also have representatives from the IT Directorate, Research, Quality Management, Monitoring and Evaluation, which has been very instrumental in our data dissemination activities, as well as implementation of interventions at the center. And then for the team, again, I said it's a subgroup of the AMS committee. The team meets more frequently than the committee. We meet weekly on Wednesdays, and it consists of 4 pharmacists, a doctor, medical laboratory scientists, and then a nurse with IPC experience. And then this is the organogram for the AMS program. Structurally, the program sits within the Pharmacy Directorate with a full program manager and part-time deputy, and it coordinates with peer committees, that is Infection Prevention and Control, Quality Management Committee, and then the Medicines and Therapeutics Committee. So the key design of the AMS program is that we didn't create an isolated program. We coordinate with other relevant committees at the center, that is IPC, Quality Management, and Medicines and Therapeutics Committee. So data that we generate feeds into activities of these committees as well. And then the next thing, after setting up the committee and the team, the next thing we did was to build capacity in committee members and team members. And with this, I'd like to emphasize that you do not need a training budget to start. We take advantage of free learning resources from WHO, Stanford, Future, and CDC. There are so many free resources, so we put them together and then shared with all the team members. They had to take the courses and then submit certificates of completion after each course. And then from training, we performed a situational analysis. Before making any interventions, we wanted to map out where we stood, what was in place, and then what was missing. And this gave us grounds for our action plan. The action plan was built in reality to our situation rather than assuming assuming things that we didn't have in place or things that we had in place. And the situational analysis was based on a tool developed by the WHO. So you see the element on the left-hand side of your screen. There's the tool that can use to perform situational analysis to identify gaps in your practice. And that would inform the action plan that you develop eventually. So based on the situational analysis, we developed an action plan, and that including testing baseline antimicrobial prescribing. Assess baseline antimicrobial prescribing to the global point prevalence survey. We have done that over the years. I think we've done it since 2021. We've had it consistently. We missed it in 2022, however. And then we've also had some targeted audits on community-acquired pneumonia, surgical prophylaxis, and specific agents like meropenem. So this prevalence survey also helps identify gaps in antimicrobial prescribing and helps you streamline the kind of interventions you want to put in place. And so this was information from this was added to what we gathered from the situational analysis, and this guided the interventions that we developed over the years. And so there are several validated PPS methodologies. However, we use the global PPS because it is standardized and lets us benchmark against other hospitals nationally and then internationally. And I believe we've shared the resource with you as well. Okay. So when the action plan was in place and we implemented the interventions, four rules that the team in UGMC lives by is by starting small and achievable. We targeted the low-hanging fruits, making sure that we had policies in place, guidelines, and then we always pick a quantitative measure each year. We set a goal that we can assess quantitatively and then measure it at the end of the year. And then education and training is also one of the key interventions that we put in place annually. So, yes, and as part of the interventions, we had to adopt AMS strategies. And so internationally, there are two major approaches to antimicrobial stewardships: the front end or pre-prescription approach, and that includes formulary restrictions or pre-authorization requirements for specific agents, and then the back end or post-prescription approach, which includes prospective audits with intervention and feedback. And most successful programs combine both approaches. However, when starting the AMS program, we advise that you start with the back end or post-prescription approach as it is less confrontational to introduce, and gradually build up to implementing strategies like the formulary restriction or pre-authorization requirements for specific agents. And so we began with the prospective audits, and now we are gradually moving to the pre-authorization requirements for specific agents at the center. So UGMC AMS activities fall under these pillars. I'm going to quickly run through them. Awareness creation, education and training, AMS rounding, research, guideline generation, and then antimicrobial audits, prescription audits. So in terms of awareness creation, we commemorate World Antimicrobial Resistance Awareness Week each year. We've had AMS EduFair, which are interactive booths to be set up for pharmaceutical companies to come and educate our clinicians about antibiotics they carry as part of their portfolios. We've done that. We've also had symposiums each year during the WOW week. This doesn't require a lot of funds. If we just group clinicians together, we have a theme. We have a topic that is in line with the theme for the year, and then we educate prescribers. We also are big on research, and so every 2 years organize an attractive where we invite researchers to come and research that are doing on real resistance and AMS with clinicians. We've also engaged the community, particularly school children, in poster drawing competitions. We also engage staff during the week. It's something our staff look forward to each year because it is very exciting. These are a few pictures from our awareness creation activities. And then education and training. I mentioned it was one of the key elements in an ASP program. And so we take that very seriously here. And each year we organize a CPD on antimicrobial, management of antimicrobial, on the use of antimicrobials at the center. And so based on it, when we identify recurring issues, we develop training modules to train our clinicians, and then we open it up to external clinicians as well. And we've had CPDs each year since the program was initiated in 2021. So these are a few pictures from the trainings. We've also developed guidelines and protocols for the management of infectious diseases at the center. When the program was initiated, the program has practically grown with the center. UGMC is relatively new, and so there weren't a lot of guidelines managing infectious diseases at the center. When I say there weren't a lot, I mean local guidelines. We do have the standard treatment guidelines, but we didn't have local guidelines streamlining our activities here. And so over the course of 2021, we have a couple of guidelines: culture and sensitivity testing protocol, surgical antibiotic prophylaxis guidelines for 8 different surgical disciplines. We have an antimicrobial prescribing policy, and then we have local guidelines for the management of community-acquired pneumonia at the center. We also, one activity that we also partake in is the AMS rounding. This started in the intensive care unit, but this year we expanded to pediatrics and internal medicine. So the goal was to establish a framework that works. And so we piloted it in the ICU, and then we tested it. And when we tested the method and it was working for us, we scaled it up to pediatrics and internal medicine. And so we do the rounds every week. We have a schedule. We round in each of the units every week. And it starts with the weekly review of patients on admission with antibiotics. And it's followed by a pre-rounding session by the medical team. And then we meet in person with the clinical team managing the patients to make any recommendations from the AMS team if there are any. And then follow-ups are done to determine recommendation and uptake. And another important thing here is that we document these activities to show the work that the team is doing. These are a few pictures. And then we also have AMS champions in each unit. Champions are dedicated staff who carry AMS into their own units. They serve as a point of contact and local advocates for the AMS program. And this is how we have scaled up beyond the core team. And the facility is quite big and the team is quite small. And so the champions have helped sustain the gains have made over the year. And if we want to do anything in any ward, we reach out to the champions, train them, and then they assist in disseminating. And partnering with other facilities has also been very instrumental in the success of the program. We didn't do all of this alone. Partnerships with Commonwealth Pharmacists Association, with the Ministry of Health, Washington University School of Medicine, Ghana College of Pharmacists. They helped bring training, mentorship, and credibility to the program. And most of these organizations are open to Ghanaian facilities, working with other Ghanaian facilities, not just us. They bring on board a wealth of experience that we were able to leverage on to implement some of the interventions that we put in place over the years. And research has also been a core activity in the program. Since stewardship generates a lot of publishable data, we've presented our findings at several national and international conferences. It serves as a medium to network with other scientists in other facilities and also create avenue for collaborating with other clinicians in other facilities in terms of the interventions that you want to put in place. And it's also how you validate what you are doing and contribute to national evidence base. And then after all is said and done, it's very important that you track and monitor effectiveness. And we do that here through our points prevalence surveys. We've had data around the PPSs, and we've also targeted audits the common infectious diseases at the center, namely community-acquired pneumonia, surgical antibiotic prophylaxis. Again, we've identified the commonly used antibiotics used at UGMC, and we have performed audits on the appropriateness of therapy for these specific antibiotics as well. So the next few slides will show what measurements actually revealed from the audits. And once you do once you have a system in place for tracking and monitoring effectiveness of your program, you need to also disseminate the findings. Is it working? What do you need to do to make it to improve the outcomes of your interventions? So over the years, this is our real PPS data, and we have done we did a baseline data from how we did the baseline data. So you see here that we had a very high prevalence of antimicrobial use at the center, but over the years, it has dropped. It dropped to 53%, and there was a huge dip in 2024 to 41%. These are all testaments to the interventions that we put in place, the education and training, the constant engagement with prescribers, the ID consults, the AMS ward rounds. All these were done in between these PPS rounds, and it shows in the prevalence of antimicrobial use at the center. Let me just quickly skip to this. Yes. And so another key thing you need to consider is celebrating gains. There are a lot of challenges that will come up when you're starting the program. But it's important to celebrate the little gains that you make. Over the years, we were able to formally appoint an AMS program manager who does this full-time as head of department. It didn't happen just like that. It's as a result of the activities of the AMS team that this came in place. We've also raised funds for our activities at the center through our partnerships and collaborations with other facilities. And then we've collaborated with our IT Directorate to develop an AMS interface to facilitate data collection. We also received grants for educational training, research grants as well. We are constantly looking for grants and collaborating with other scientists to write grants that we can use to implement our interventions at the center. And then we also have the AMS committee and team meetings. This was a challenge at the beginning of the program. However, with constant engagements, now we meet regularly, and committee members also are punctual and attend these meetings when we have them. There's also improved awareness of antimicrobial stewardship activities and initiatives, which is evident in in the previous slides, I presented the prevalence data. We see that it has dropped from baseline PPS, and that is because we are constantly engaging our clinicians. All these gains do not come with challenges. There have been some challenges over the years. For us, limited numbers of ID clinicians, including physicians, pharmacists, and nurses, and we've mitigated that by recommending that management supports the training of some clinicians in infectious diseases, and that is ongoing. Over the years, we have been able to train some infectious disease pharmacists, and that is a win for us. Prescriber resistance to changing established practices is also a major challenge for us, but that is mitigated with constant engagement. An example is when we started our antimicrobial stewardship ward rounds at the ICU. Initially, we faced a little resistance, but with communication and constant engagement, the team came to embrace us, and now we are called for ID consults. It has even become a bit overwhelming for us now because of numbers. Data collection burden also a challenge to overcome at the beginning of the program. We were doing manual data entry, data collection, and data entry, and that was very time consuming. But our IT directorate, we collaborated with our IT directorate, and now we have set up an AMS interface on our electronic medical record system, and that has helped a lot with our data entry and then analysis. Staff turnover is also a major challenge we had to face. Trained staff rotate out, and we constantly have to build capacity, and our AMS champions help us with that. So they serve as a point of contact on the wards, and so we have trained them to deliver presentations periodically, and so that the new staff they know the message of what our AMS program stands for at UGMC. We also have a slot at orientation for new staff, where we make a presentation on the AMS program, and just to make a presentation on the AMS program, just to give the staff an awareness of what the culture is here in UGMC before they go on to the wards and then get another presentation from the champions. So yes, UGMC is a 1,000-bed referral center. However, most Ghana Health Service facilities are not, but you do not need to be to start the AMS program. I understand that the Ghana Health Service follows a tiered model, so every facility will be different in how they'll be implementing their AMS program. So we put together recommendations for each kind of facility under the Ghana Health Service to see how you can implement an AMS program without all the resources needed. So for primary healthcare facility or district facilities, we put in place just a few action points. So what you can do is to name one focal person, usually the pharmacist, and we recommend that it's written into their job description, and then they get a management memo. It can be one-page signed that this is your mandate. You're supposed to do A, B, C. It has to be formalized, and adopt the national SCG whilst working on writing institutional guidelines. We realized for our setting, we realized that we couldn't work with the national SCGs. We had to local based on local antibiograms. And then you have to keep track. You can also keep track of antibiotic interventions once a quarter from dispensing records. It's nothing too tedious. Once you are able to get more resources, you can increase the frequency, but that will give you some idea of how well prescribers are doing in terms of antimicrobials. And then you pick one target. Each year, you pick one target. For example, you can pick the monitoring of the duration of surgical antibiotic prophylaxis. And then you look at how you can, you do a baseline, you implement an intervention, and then you assess the effectiveness of the intervention. The next year, you pick another target. These are for smaller facilities without a lot of resources. And also a lot of free online resources to build capacity in whoever will be assigned to implement the program in a district or primary health care facility. So for the first 90 days, you should target naming a person who will be responsible, a focal person who will be responsible, getting assigned mandate, and then having one baseline count of antimicrobial prescribing practices in the facility. And then when we which is a regional or district hospital, they may have a basic lab or no dedicated ID physician and a small pharmacy team. Here you build a small team inside an existing structure, and then you prove that the model works in one unit. You measure, then you scale it up. So what I'm saying is that you form a small AMS team, usually about 4 to 6 members. It would include a pharmacist, a physician, and IPC, someone from the lab. It's very important that anytime you are building a team, it has representation from the relevant stakeholders. This enhances acceptability of interventions and even the implementation of the interventions. Once a team is formed, they need a terms of reference. And again, we have templates we can share with you. And for the districts or regional hospitals, you can report it into the existing medicines and therapeutics committee, or if you have a quality committee, you should embed it into an existing committee. Do not create a new structure. And then you run a global PPS round and adapt national guidelines for, let's say, management of community-acquired pneumonia or surgical antibiotic prophylaxis. And then you start ward-based reviews in one unit, looking at what we are doing is to be effective, you assess the effectiveness, then before you scale it out to other units. And then we also recommend building a facility antibiogram at least once a year. So for district hospital, we are recommending that in the first year you target one PPS round, one local guideline, one audited intervention at the facility. And then when we come to the third tier, that's the teaching healthcare facilities. We are assuming they would have a full lab and some form of IB expertise, and then they would have a broader multidisciplinary depth. So with these kind of facilities, we recommend having a AMS committee plan, an operational AMS team like the UGMC model, and we recommend appointing someone full-time as an AMS program manager. That was the game changer for us here. It shouldn't be voluntary, it should be in their job description. And you can explore prospective audits and feedback before progressing to formulary restrictions. I mentioned before that there were 2 different kinds of strategies. The less confrontational one, which is easily acceptable by other clinicians, is the prospective audits and feedback. Then once you gain some form of trust, you can escalate to the formulary restrictions. And you can also look at routine AMS ward rounds like we do here at the center, and then have annual point prevalence surveys, look at research, look at having an AMS champion. And another that I have seen in other facilities, I think some Ghana Health Service facilities practice this, having a hub and spoke model. If I remember correctly, LECMA practiced this in a certain project I was privy to be part of. So LECMA was the center that had an established AMS program, and they were mentoring other facilities close by to help them set up the AMS program. UGMC is also available to serve as a hub to other facilities. So for these kind of facilities, the teaching healthcare facilities, we want you to target using ongoing data, doing a lot of publications, and then using the hub and spoke model to build capacity in other smaller facilities close by in the same thing. So yes, for these three different levels of care, these are the recommendations that the UGMC team is making to you. And I'd like to conclude that there are three key takeaways that I want us to take after this presentation. That in order for the program to succeed, you need to involve everybody. It is not just the managers that need to be involved. Everybody needs to be involved to make the program succeed. And stewardship works even in limited resource settings. It's very important to target low-hanging fruits, and once you're able to see some results, you disseminate the findings. Sharing the data is very helpful in ensuring acceptability of interventions. And everybody, no matter what year they are in the Ghana Health Service sector, can part in making sure that the program is successful. So I will end here. And if there are any questions for myself or the team, we are happy to take them now. These are some resources that I think we have shared with the team already, but we can reshare after today's meeting. So thank you for your time. We are happy to take questions now.
Okay, so Nana, before the questions come in, thank you for the presentation. I would like to reiterate a few things that you talked about. The first thing is that I said it the other time, and I would repeat that management sensitization and commitment is important. When the vision is born, you need to carry the other people along. The program will be. And for all the facilities that we intend to start the AMS program in, we have to work from the top. And so we have to get the top management interested, involved, aware. Then it will trickle down. The second thing is that the role of a work plan should be emphasized. Every team or every program for a particular work period, whether it's a year or 6 months, you need a work plan. And the work plan is the guide, or it will be the guide for the program. Periodically over here, we do work plan evaluation to find out how we are doing in terms of achieving the goals on the work plan. The third thing is the utilization of the feedback from audits. And so there are times that we realize that there's in pulmonary coverage in the ICU or dual anaerobic coverage from the ward, or we think that there is a need for proper contact isolation, and this is gotten from our ward rounds and our folder reviews. Quickly, we put in place measures to address these. And we target the areas where the problem is, talk to the team, educate them, and then we can even retrain. The other one now talk about is the need for commitment, and then the need to identify self-motivated people to carry the program. If you force people to run the program, it will fail. And so you have to identify people who get the concept and who are self-motivated. Oftentimes, I get staff and they want the interest in getting the team, they're interested in getting for me. And then the question is, what is in it for me? Or how much will I get paid? If the structures are in place for motivation to be given, fair enough. But the trick is to get people who are self-driven from the onset, and they'll carry your program. The other thing is that there have to be conscious decisions. So for my tenure as the director, I called for the setup of the AMS program manager's office. And so if the directors are not committed and involved, this will not happen. It means that you also have to dedicate staff from your short staff or from your new staff to start the office. There was a lot of opposition where some heads of classes collaborate and they will actually need people at the unit, and you have designated this pharmacist to be at the program office. What at all happens there? There's nothing. But if you understand what you are doing, you are happy to commit people and even request for admin managers for management. So, I mean, the leadership must get the concept and fight for or commit people. Once this is coming from the top, from your end, then from the onset, you need to dedicate people who will work as pharmacists who will run the program, and then administrative officers. You need to have a dedicated office or officers. Give them resources, computers, internet, printers to run the program. That is also one of the secrets of our success. Then, lastly, I will say that in naming a four-person, you to be advisable to have a pharmacist and a doctor co-chair or co-lead. That is fine, but you identify people who will lead and drive the program. In a setting, you can have it that you think that if one cadre promotes it, the other cadres will not be so attentive, and so you try to get leadership of the other cadres involved. Look at what works for you, and then you work on it. And as time goes on, what you start may go down because of the attrition rate or because of change in officers. For example, we used to have a slot at the onboarding of every new staff that comes to UGMC. At the point we realized that we were not invited for onboarding or orientations anymore. So we had to go find out. It was just an omission that they continue. So we changed that directive, and then we got on board, and now we are also involved. So you need to keep your ears on the ground. Things that are dying up, you will correct it. Thank you very much for your attention.
Thank you so much, Director Pharmacy, and thank you, Nana, for that excellent presentation. I can actually see that you're committed to helping us because already you've gone ahead to come up with great recommendations and suggestions for us. That part I did not expect at all, and I'm very excited about it. Thank you so much. A lot has been shared on this presentation. Yeah, I've taken keynotes that no matter the tier of service, we still can do this. It doesn't need to be capital intensive. We only need to be committed to it. And it is key that we collaborate both externally and internally. Like you rightly mentioned, the IT has been very instrumental in the success of this. So we've taken keynotes from all that you have shared, and we are so grateful for the knowledge shared and your great recommendations. Please, at this time, I will open the floor, or I will leave it for my other team members to speak up about anything that they want to share, anything they've learned, or any suggestions.
Lady Edna, thank you for the opportunity. I want to say thank you.
Please go ahead.
Yes, I say thank you for the presentation. I'm just excited about the fact that they mentioned that, well, despite the fact that we can have uniqueness in our modus operandi like them, we can always tailor it to suit, let's say, the facility, the teaching, like the facility, the regional hospitals, and then the district hospitals. So I think all in all, it's a good one, and it's a good way for us to continue to discuss what we want to do in terms of the TWG and the committee. Thank you once again, and over.
Thank you, Dr. Claudette. Please, any more? You can unmute and speak up if you want to.
Now, will you take it or you want me to go ahead?
Please go ahead, Director.
All right. Thank you for the question. They are different. In fact, I will add on a third one, infectious disease consult, to it. Okay. Can I go on?
Yes.
Okay, so the PPS is a point prevalence survey. That is a one-time or one-day survey, like a one-day research that is conducted by an institution to look at, you take a snapshot of antimicrobial utilization at the facility. So it usually to 8 p.m. or from 8 p.m. on that particular day. And so we have a tool. We have a tool that we use to take the data. And after taking the data, we enter on the global survey platform, and it will generate your findings for you. It will actually match your performance with the national, that is the Ghana data, and also the global data. We use point prevalence surveys to take information on how we are doing as an institution with antimicrobial use and how the prescribers are doing and clean up our recommendations. We do this at least once a year. Now we do it even frequently to take in information and to monitor. For every antimicrobial stewardship program, we recommend that you do a baseline point prevalence survey to identify your challenges. That is like a fact-finding survey that helps you to, it gives you a clear picture of how you are doing. Our first point prevalence survey realized that about 70% of infections treated here was pneumonia. About 70% of our antibiotics were used to treat pneumonia. Then we realized that, hey, as a committee, we have to develop pneumonia treatment guidelines. In the first point prevalence survey, we realized that surgical prophylaxis could go up to 5 days, 1 week, without any indication. We added that to our work to streamline surgical prophylaxis. So the point prevalence survey is a one-day snapshot of antimicrobial utilization at a facility. The AMS rounding is a specialized form or a special form of rounding conducted by the AMS team or the infectious disease team. And this is how we go about it. For AMS rounding, all patients who are on at least one antibiotic are under our survey. If you are not on an antibiotic, AMS rounding will not capture you. So I'll give you an example. Maybe there are 5 patients in the ICU. 3 of them are on antibiotics. It means that automatically we have to round on the 3 when we are doing the ICU rounding. The way we go about it is our pre-rounding, where we have residents who already who filed a case. We have a template that we use and dig out salient information. And during the rounds, the specialist, the senior specialist or the consultant will give recommendations. We all agree on our recommendations. Then we go to the ward. So typical example, pre-rounding AMS is 11 to 12. Then we can go and have our lunch. 2 p.m. we are on the ward. And because we have already done pre-rounding, we speak the same language. And any of the ID specialist pharmacists can lead the round. So we would mention the patients, we'll go through the case with the ICU team, and then we will give our recommendations. It means that we have already prepared for them. And so it's usually very successful. That is the AMS round. So we do in the ICU, at the medicine, and at the pediatrics department on different days. The other one I'm adding is the infectious disease consult. That one, any time of the day, any time of the week, it can be morning, evening, weekend, when there is a hard to treat infection or when there are patients on specialized antibiotics, the doctors have the liberty of calling us to ask for our opinion. So usually I'll get a WhatsApp message, ID consult. Whenever I see any consult, I will call the person back and they would tell us, we have this patient who is this and that and that and that. What do you think? We will ask questions, we will make recommendations, and then they will enter it at the hospital, ID consult, plus Pamlanama, plus Dr. Mensa, plus Prochi, write the recommendation and implement it. That's the difference. Thank you very much. Over.
Thank you for that clarification, Director. So basically, just to add on, the antimicrobial team is the same team that does the PPA and the rounding, right?
Initially, from the onset, it was the team that did the PPS, but now we have expanded. I'll leave it for Nana to talk about it. We have involved other people. She will talk about it. For the rounding, it is done mainly by the team. It is done by the team, and it is led by the infectious disease senior specialist pharmacist or the specialist pharmacist or the infectious disease consultants. So the rounding is led by the specialist, the senior specialist, and the consultant. Now let's talk about the PPS.
Okay, so with the PPS, initially the team used to do the data collection, data analysis, and the dissemination. But then we realized that the uptake of the outcomes was not ideal because our prescribers were still not getting the concept of why we were doing the PPS and the relevance of the data that we were sharing. So in order to promote ownership of the data that we generated from the PPS, we expanded this year by training pharmacists in each of the units. So pharmacists in each of the units were trained on how to do the data collection and just understanding the concept of the PPS. And then the AMS team then we do data analysis and then the slide decks for the various units. And then the pharmacists in the various units are responsible for dissemination of the findings. So currently the dissemination of the first quarter PPS is being done by pharmacists on the various units at their clinical departments, all in our efforts to promote ownership of the data that we generate from the point prevalence surveys. Thank you.
What I'll add is that the head of the clinical and inpatient pharmacy is a member of the committee and a member of the team. So it makes the work easy for us. She will get the pharmacists at the various units to coordinate the PPS and disseminate, and we take feedback from her and her team.
Well, very well noted. Thank you for explanations given. We've taken note of them. So others are trained about the rationale and how to conduct the data and dissemination, but the analysis is done by the team. Okay, well noted. Thank you. Please, team PSD, any more?
Thank you. I would start and then now add on. The number doesn't actually matter. So when we started, I think the antimicrobial use was very high, and as time goes on, we are improving. So the number doesn't matter. Any number that you find to be on antibiotics, you work with them for a particular facility. And so it's all good. I remember we were doing an audit on the use of institution 2 years ago. The numbers were very high. Now we are trying to do an audit and then realize that the numbers have gone down. And so for the research that we are doing, we have projections for the numbers. We are not meeting that target. But the thing is that you were like, hey, you mean that whatever we are preaching is going down well, and so it doesn't matter. Now you can add on over.
Okay. So yes, like Dr. Mensah rightly said, it's a 1-day survey, and so it's supposed to be a census. So whatever number you get, you work with it. There have been instances where we've done the survey and we go on a ward and we do not have any patients on an antibiotic, and that is the limitation of the PPS. So that is why, as a program, we couple PPS with protective audits. So if one day we do the PPS, we don't get anything, it can be a positive finding. But then again, we delve deeper through the prospective audits to see patients who are on active antibiotics and evaluate the appropriateness of therapy on the wards. So I can give an instance. This year, the first quarter PPS we did for the OPD, we surveyed about 50 patients, but we had just 4 on antibiotics. So we reported on the 4 that were on antibiotics. We saw it as a plus for us. But then we still prospective audits to make sure we are doing the right thing in terms of antimicrobial prescribing. Thank you.
Thank you very much. Please start off. Anything you want to add?
No, thank you.
Okay. Dr. Eke, please, anything from your end? Oh, it looks like she dropped. Okay. Thank you. Thank you so much, Team UGMC. We are most grateful for this insightful presentation and most of all for your recommendations. Luckily, Director is in the house. So Before we will sign off, I would like to call on Director Pharmacy at Ghana Health Service to give us a closing remark.
At the inception, but unfortunately, I was problem than looking at head office. That's why I couldn't do. But I think I found in the last 15 minutes. So I want to thank Dr. Mensa and the team for their very support the office. Anytime we call them, we are most grateful to them, and also they are doing mediums. And I said, we should leverage the expertise to ensure that we also work very well Antimicrobial Stewardship in this sense. Interestingly, I like the comment the two key things that underline the success of Antimicrobial Stewardship in the prison was one of the key things that is really militating against the success of establishing Antimicrobial Stewardship programs and, of course, PTC teams in our hospitals is the fact that most people who are supposed to join the team are not serving in the financial requirement. So once they join one team, they realize they don't understand the now the dollar. But another point, we should also ensure that those who we can select those who that are supposed to take part in these committees. And the second issue she also mentioned, which I also agree with her, was management commitment. That is very key. If you don't supporting such critical documents, you will not obtain accountability. So taking note of the issue and like I said, we will continue to call to support and so can strengthen not only Antimicrobial Stewardship, but also DTCs in our healthcare facilities. On that note, I thank all of us for taking part in this. I thank very much for community stepping in and show that. Thank you very much.
Thank you, Director, for thanking me. And thank you all so much for making time to be with us this afternoon. And Team PSD to thank you for paying attention. Your questions reflected the fact that you paid attention to the presentation. So thank you very much. Anna.
Before the next comes in, I would also like to thank my team. I have a solid team here, and I want to thank all of them. Anna, Freeman, Farida, and everyone in the team for making our program this successful. I'm grateful. Anna?
There's a hand up. Please unmute.
Hello. Sorry, my network disappointed me, so I was off. I would also want to say thank you on behalf of the IHP, that's the Integrated Health Partnership Program team, for organizing this meeting with us and also accepting to support us in every way. Thank you, Nana. Thank you, Dr. Mesa and your team for your support, as we are very grateful. We much appreciate this. Thank you.
Thank you all for making time to join us today. All my directors have spoken, so there isn't much I can say. But thank you, and we are very happy to share our experience with all of you. And we are available anytime you have questions. Please have a nice day, and Enjoy your weekend. Bye.
Bye. Thank you very much.
All the best to you.
Bye.
Thank you.
Thank you. Bye.
You keep in touch. Bye.
Bye.
Bye.